Welcome to Channel 17, the Town of Colonie Government Channel.
Hello and welcome to Focus on Health. I'm your host, Peggy Mello. Today's guests are Dr. Peter Horvath, a reproductive endocrinologist, and Marsha Forman, an embryologist from Albany IVF. Welcome to the show.
Thank you.
Thanks for having us.
Let's first define infertility.
Infertility is classically defined as when a couple's trying to get pregnant and they're unsuccessful in doing so in about a year's time. That's modified a little bit for older women. Fertility rates go down as women age, and most people kind of know that commonsensically. So for women over the age of about 35, after about 6 months of trying, it's not unreasonable to begin an investigation.
Okay. And how do you generally diagnose infertility or diagnose a problem? What are the steps that they go through?
Well, you know, reproductive medicine doesn't follow the typical sort of model that most people think of when they think of going to a Western doctor. You know, you have a problem, let's say you have burning on urination or something, you know, you have a problem, you go with a complaint, you do a test.
Right.
You draw a urine culture, maybe you send it to the laboratory, get a bug growing. You treat that bug with an antibiotic and then the problem goes away. So there's a problem, there's a test,
Right.
and then there's a medicine or a surgery that fixes the problem. In reproductive medicine, that model isn't followed, unfortunately. The testing that we do isn't so, you know, people want an answer, why isn't it working? But the tests that we do really aren't designed to clearly give an answer. If we do give a clear-cut black and white answer, it's usually not something somebody wants to know. You're not getting pregnant because you have no sperm, or because you're menopausal, or some major abnormality that's, you know, as a single factor might explain the infertility. Usually what we're testing for is contributory factors, and there are whole hosts of them, and about half the time the man is involved and about half the time the woman is involved. On the female side, the most common problems relate to ovulation problems with the fallopian tubes, less commonly problems with the uterus or cervix. Sometimes there are, you know, I mean, this may sound odd to some of the listeners, but, you know, we're very busy. And sometimes it's just coital and timing issues, trying to, you know, the wives are working, you know, one shift and the husbands are working another shift, and they're trying to have as much intercourse as they can, but sometimes just getting that timing together is difficult. So there are whole hosts of different reasons, and typically there's multiple factors. You know, it's not just one thing that's causing the problem. It is a couples related problem. So in fact, that's another misconception, is that you know, it might be a remarriage situation for some situations where, you know, the gal already has children, maybe the guy already has children, they were fertile before and now together they're having a problem. So I think that's an important concept, is that it's a couple's problem and that it's typically multifactorial.
And you're generally actually looking at both the male and the female.
Right.
In the couple.
Right.
And what sort of testing would you generally do as a workup for them?
Well,
is there something that actually happens that you do for everyone?
Pretty routinely, yeah, there are. As I mentioned, the general areas I mentioned before: ovulatory problems, tubal problems, certain anatomic issues, male problems. On the female side, we would do a hormone evaluation for medical issues: thyroid disease, adrenal disease, pituitary problems. These are hormonal systems that impact ovulation. We would typically do some sort of screening anatomic test to make sure that the fallopian tubes are at least open. That's typically a test called a hysterosalpingogram, which is a dye test where we put an X-ray dye into the uterus and up into the fallopian tubes and then visualize that with X-ray. We may also look at the uterine cavity with a test called a sonohysterogram. That's a test where we inject water into the uterine cavity and visualize the uterine cavity then with ultrasound. We may monitor a woman's cycle, an ovulatory cycle for the woman very carefully with blood work and ultrasound monitoring. And then on the male side, we do a semen analysis, and I'll let Marsha kind of talk about semen analysis a little bit.
Right. At Albany IVF, we have our own independent laboratory that is able to process male samples not only for initial analysis, which would include multiple parameters. So we would look at how much sperm the gentleman has, how the sperm are moving, and what the sperm actually look like. And if we believe that the sperm are, what percentage of the sperm we believe are able to reach and potentially fertilize an egg. So if patients were going to attempt pregnancy through natural intercourse, or whether they were using an assisted reproductive technology such as insemination, those patients would have very good normal or above normal semen parameters. Our laboratory also has its own endocrine lab, so we're able to run our blood hormone assays. So when Dr. Horvath orders tests on a patient initially to see where she is, if she's going to be ovulatory, if she's menopausal, if she has any sort of an endocrinological issue, we can see that right at our own facility and be able to adapt and work with that patient to help her get pregnant.
Which helps, because otherwise you'd be waiting
days, hours,
for results.
And as we all know, the body doesn't wait. Ovulation happens when it wants to, so we need those answers immediately.
Now, you've mentioned that age is a factor in fertility. What are some other environmental factors that can influence fertility?
Well, the environmental factors, it's tricky because, again, multifactorial. There are clearly environmental factors for men and for women. Certain medications may be a problem. Chemotherapy, right? Environmentally, the quick sort of lifestyle things that people, might be exposed to. Cigarette smoking is probably the single biggest sort of toxin that's out there that should be avoided.
And that affects male and female.
Male and female. Everybody knows that cigarettes are bad for you, and this is yet another way that they're bad for you. So on the male side, men who smoke the DNA, the genetic material in the sperm, tends to fall apart more readily. And for women, it is a toxin to the ovary, and the eggs for a woman are actually created only once in her life. Back before she was born, when she was about a 5-month-old fetus, is when a woman has her peak number of eggs. And so if she's smoking, especially lifelong, she's exposing those eggs to these toxins for a long period of time, and it is a cumulative effect. So, again, a woman might have been fertile when she was 18 or 20, and now if she's, let's say, 30, her fertility might be significantly different in that decade, particularly if she had environmental exposure to things like cigarette smoking. Lots of, virtually any drug, illicit drug, use would certainly would be something that you'd want to avoid. For men, the most common sorts of issues environmentally relate to exposure to, say, fumes and solvents, and then also heat. So certain occupations for men are a problem. Firemen, right? Cooks, chefs that are around a lot of heat. Guys that work in auto body shops, things of that nature. Not that you can change your career, or your job necessarily, but you want to make sure that you're following, occupational safety and health regulations and doing whatever you can to kind of avoid those things. And then finally, I guess one last thing that is a factor both on female and male side is overweight, obesity. Obesity is a big health problem in the country. Again, for whole hosts of reasons. We usually hear about cholesterol and heart disease and high blood pressure and that sort of thing. But overweight also impacts reproduction, again, both on the female and male side. So that's another thing, that being in good general physical health while it doesn't cure fertility problems, that's sort of another factor that's out there that if you can get a control over overweight, smoking, those sorts of things, those are important factors.
I've heard that stress is also a factor as well.
Stress, stress certainly impacts our hormones. I mean, the classic example is, you know, sort of might be the woman who's having unprotected intercourse and not hoping to get pregnant, and she's so worried about the fact that she may have had exposure and she doesn't want to be pregnant that she actually throws her cycle off and doesn't ovulate because she's so worried about it.
Okay.
And you know, that's an anecdotal story. I mean, I think one of the untruths out there is that stress per se causes infertility. I mean, there is nothing more upsetting to an infertile couple than to hear somebody say, "Oh, just relax, you know, you're too worried about it." Stress impacts ovulation. It certainly can impact and does impact the immune system in ways that are not so clear. And so, yes, stress reduction techniques, massage,
Acupuncture.
you know, acupuncture, chiropractic, all of these sorts of alternative modalities may certainly be helpful in reducing some of that stress and in helping people feel that they're doing everything that they can. But those things are not, stress alone is not the cause, typically. There are lots of people who are very stressed out who nevertheless get pregnant when they come for, you know, care.
And somehow they have to stop themselves from being too stressed out when they're actually in the treatments as well, going to you on a regular basis.
I think the biggest piece of that and the biggest work for couples and maybe what engenders some of the greatest stress is the lack of control. There's no control.
Right.
So whether you come to a fertility center and you embark on advanced techniques and high power techniques and expensive techniques, or whether you take herbal medicines, or whether you know, see that acupuncturist or chiropractor, you could be the perfect patient and do everything that we're telling you to do, and it still may not work.
Right.
And so that's where the stress is engendered, because in the end, you know, the fertility and reproduction brings up issues related to self-esteem as an individual, you know, parenting issues, friends and family, you know, who are wondering why you're not getting pregnant. So there are whole hosts of levels where it impacts both your individual sense of self as well as your relationships, not only with your partner, your spouse, but, you know, your more extended family and friends.
So you are a reproductive endocrinologist.
Right.
What sort of training is involved for that? Obviously, you're an MD.
Yeah, step one, I guess, is medical school. After medical school, you know, basically to get a license, you have to do 1 year of training. That's the internship, so-called. And beyond that, people choose a residency in whatever specialty they want. Reproductive endocrinology is actually a subspecialty. So the first specialty choice is OBGYN, obstetrics and gynecology.
Mm-hmm.
And within obstetrics and gynecology, so that's a 4-year training, obstetrics and gynecology. And then beyond that, about 7% of OBGYNs decide that they want to get even more specialized. And so there are 3 or 4 subspecialties within OBGYN: GYN cancer, high-risk maternal fetal medicine, high-risk obstetrics, and reproductive endocrinology are the 3 major subspecialties. So reproductive endocrinology is the study really of reproduction, female hormones, and largely fertility. So that's an additional 3 years on top of the 4 years of the OBGYN. So you're about 30 by the time you get out if you go straight through.
And there's also board certification for that as well, right?
Right. There's board certification for both the general OBGYN and then also for the subspecialty, and you actually have to maintain both. You know, you have to still be an OBGYN in order to be a reproductive endocrinologist, and there are different ways of getting that certification. I think most of us with the gray hair are doing it on a yearly basis, so there's a yearly certification process that we go through.
Okay.
Make sure that we're not getting stale and that we're up to date on what we should be up to date on.
Which is important. And how long have you been practicing?
20 years.
20 years.
Yeah.
Okay. Okay, Marsha, it's your turn.
Yeah.
What is an embryologist, and how do you become what you've become so far?
Right. Well, an embryologist is a scientist or a laboratory person that is going to observe gametes, which would be either your eggs or your sperm. Most of the time we observe them in vitro, which means we're using a petri dish or outside of the body. And we're looking at the sperm-egg interaction. But as an embryologist, you also kind of cross over your field into andrology and endocrinology, which is the hormone studies and kind of monitoring where the follicular development is in the woman and how she's doing endocrinologically, as well as what the male proponent has to offer. So is there sperm? What is the condition of the sperm? Is the sperm likely to fertilize an egg on its own, or does it need mechanical help? And unlike Dr. Horvath being a licensed practitioner, embryologists are not licensed currently in the United States. However, they are in several other areas of the world. When I became an embryologist, when I got my education as an embryologist, there were 2 schools to get an actual clinical or formal training in embryology. And one was in Australia and one was in Leeds, England, which is where the first test tube baby was born. And I applied there and went there to get formalized training. And so now, that was about 5 years ago, and now there's 3 or 4 schools in the United States. So the United States is a little slower to catch on, but now there are places where people can get a formalized education in human embryology, not just animal husbandry, which is kind of what the old embryologists learned on, and then they kind of moved into the human model.
And you're working on
I'm working on my PhD right now. Right.
And that would be a PhD?
It's actually in public health.
Oh, in public
Yes.
health.
Yep.
Okay. Very good. All right, so now we're going to talk about treatment for infertility.
Okay.
Where do you begin? There's pretty much broken down into 2 avenues, right?
Right. It's how I break it down really is that there are 2 major treatment arms. The first treatment arm, and Marsha alluded to this a little bit earlier, involves intrauterine insemination. That's a technique where we concentrate husband's sperm, and I kind of say to patients, we give them a cup of coffee. This is what the lab does.
Right.
We give them, make them extra zippy, extra peppy, and then take a concentrated sample of that sperm and put it up high into the uterine cavity, up on the day of ovulation. And typically with intercourse, what happens after ejaculation is, tens of thousands of sperm get captured by the cervical mucus and make it up into the upper reproductive tract of the woman, but the tens of millions of sperm that are ejaculated leak out of the vagina when the woman stands up. So with intrauterine insemination, we're actually taking typically 2 orders of magnitude higher numbers of sperm than would normally get up into the upper reproductive tract and putting it up there. And I think there'll be a diagram that viewers can look at of what that actually looks like. It's a largely causes minimal cramping for women. Most women do very, very well. It's not a painful procedure for the vast majority of women. And that technique can be done either without any fertility medication, so in an unstimulated, unmedicated cycle, just timed to the woman's natural cycle, or it can be done with the adjunctive use of ovarian stimulating medications. And those are broadly broken into pills and injections. And unfortunately, the reality of the statistics of how this stuff works is the less aggressive you are, the less well it works. And the more aggressive you are, the better it works. So, for example, and it also, of course, what are you working with? Are you working with really good quality sperm or not so good quality sperm? And what are the different factors? I mean, if it was a coital issue, where all we're trying to do is get sperm on board at the right time because the couple wasn't timing their intercourse well, then very simple approaches may be very effective. But for couples where their timing was good, with intercourse, then often we have to move to the more aggressive approaches. The second major treatment arm, other than intrauterine insemination, is in vitro fertilization. In vitro fertilization is done almost universally with high doses of stimulating medications, so ovarian stimulating medications. where we are trying to get the woman's ovary to mature many follicles. The follicles are the specialized cysts that contain the eggs. Normally, without medications, humans only have one baby, typically. Our twinning rate is only about 1%, and triplets without fertility drugs is 1 in 10,000. Well, with fertility drugs, it's much higher than that. And so
IVF has the fertility drugs that tend to cause multiple births.
That tend to cause multiple follicular development. And so with in vitro, the difference is that once those eggs are matured, rather than having them be released by the ovary in the normal way and adding sperm up into the reproductive tract to have fertilization happen in the fallopian tube the natural way, with in vitro we're actually going in with a needle, retrieving the eggs out of the ovary prior to their release, and then the laboratory, the embryology team, assists in combining the sperm and egg in the laboratory, and the embryos that subsequently form are then selectively chosen and placed back into the uterus. So rather than putting sperm into the uterus, which is what happens with insemination, in the case of IVF, we're actually putting embryos back into the uterus. So it's a more intensive technique, and it really, one of the key differences there is it gives us information that insemination therapy doesn't. Because now we're actually looking really for the first time at the woman's eggs. We can never really look at a woman's eggs with anything short of using the in vitro type technology, and that's sometimes the fertility factor is a problem with the eggs. So in vitro not only is the most effective thing that you can do on a month-by-month basis for most patients, but it's also a very powerful diagnostic test. Marsha, I don't know if you want to comment on that.
Well, I think, when we get the eggs into our laboratory, sometimes we have a patient who looks what we would call textbook. She has a great endocrine cycle, her follicular development is excellent, and when we get the eggs, and we do put the eggs and sperm together, we have what we call fertilization failure, meaning we know that the sperm were actually injected into the eggs. We understand that the two components were put together mechanically, but they still were not able to undergo what they needed to do in order to cleave and form a viable embryo. And like Dr. Horvath said, that's a very, very sure way to help diagnose, what's happening for the patients. And patients do want to have an answer. So it does help give them some sense of understanding why all this time it hasn't been working. And there's some relief, I think, for some patients for that, and others, well, is it like that every time? Is it always going to be like that? Can we try again? And sometimes it's like that one cycle, and the next cycle may be very different. So I think that for most of our patients, we let them try as many times as they would like to try, and each time giving them the appropriate counseling as to what measures we can take to potentially alter a cycle or alter a treatment to give them the best outcome or the outcome they desire.
So if somebody's going to come in, you generally know when they're ovulating because they're taking their temperatures at home and they know? Or are you testing?
We're monitoring. We don't know anything until we look, really. And so temperature testing, you mentioned that as something some of the viewers may know. That basal body temperature is the woman's temperature when she first wakes up in the morning, before she gets up to empty her bladder, before she gets up to make her cup of coffee, that very first temperature when she opens her eyes. That basal temperature is affected by her cycle. So progesterone, which is the hormone that's dominantly produced in the second half of the cycle, actually causes that basal temperature to rise by about 0.5 degree. And so if a woman takes her basal temperature every morning, she can, on a chart, look to basically ascertain when did I ovulate. And the problem with that is, though, that it's not predictive. It's not when will I ovulate, like tomorrow or the next day. It's looking back at the graph. She can say, oh, it looks like I ovulated 2 days ago because now my temperature's been up and has stayed up. So that's a good test for kind of, if a woman is interested to know, gee, I have pretty regular cycles. I wonder if I'm ovulating occurrence, not quality, but I wonder if I'm ovulating. Then doing a basal body temperature graph is a reasonable way to ascertain that. and then retrospectively she can say, this is when I ovulated, and we can get some sense then of how long the second half of the cycle was, which should be about 2 weeks. It should be about 14 days from the time of ovulation until the time of the period. And for some lucky women, they may be taking their temperature and trying to get pregnant, and if their temperature stays up for 16, 17, 18 days, well, they may be pregnant because pregnancy, in pregnancy, progesterone continues to be made, and so the temperature stays up and they don't get their period. And but that's a useful tool. We don't use that at a subspecialty level very often because we're looking with more advanced and sophisticated techniques, the hormonal endocrine test that Marsha mentioned, and the ultrasound monitoring of follicular development. Again, these specialized cysts that contain the eggs.
So for the IVF patients, how often are you seeing them in 1 month? I mean, how do you know? Do you set an appointment 2 weeks in advance and say, or do they just call you and say, I have to come in today?
No. In vitro fertilization really requires that we, in a sense, control the cycle. So we can give and the medications that we use to control a cycle are sort of intuitively sound wrong because they're anti-fertility medications. Things like the birth control pill. There are analogs of a hormone called gonadotrophin-releasing hormone, GnRH. And so there are different medicines that we can use to essentially kind of stop a woman's cycle and get control of it. And then we artificially stimulate the ovary with the fertility medications. So it's very organized, and there's a calendar. You know, we have what we call your calendar, and our coordinator controls the calendars. And so, you know, it literally can be controlled to the point where, you know, we might give a woman her calendar, and then she says, well, it looks like I'm going to wind up with my egg retrieval in this particular week, and that week is a really busy week for my husband. He's going out of town that week. What do we do? And then we'll say, well, we'll just leave you on the pill for 3 or 4 more days until he gets back. So we can.
So you can actually control. I don't want to say control it, but
not to the day, but to the week. So we can't predict what day a woman will be ready, but we certainly can predict the window. There's a window of 4 or 5 days. Follicular development from the time the egg starts to mature until the time it's ripe. There's a window there, and so we can predict within that window of 3 to 4 to 5 days.
So does the woman have to come in a number of days in a row, or do they just come in once?
No, it's typically, for the whole stimulation phase, it's probably about 5 visits on average. The closer a woman gets to being ripe, to being ready to get her egg retrieval procedure, the more frequent the visits. So, you know, one woman may stimulate in such a way that she comes in for 3 visits, and maybe she went very, very quickly, more quickly than anticipated, and she might get away with just 3 visits, and then she's ready for retrieval. Another patient might come, you know, 5 or 6 visits, where we think she's getting very close, you know, at a particular point. We'll bring her in the following day, and that following day she didn't have as much of a change as we wanted, so we might bring her back yet the following day. So, you know, we want to be as exact as we can. On average, for most patients, it's in the ballpark of about 5 visits for the stimulation phase.
And they're short visits in the morning. The patient would come in and have her blood drawn and have an ultrasound, speak with the nurse, and then go home. You know, so it's not like your traditional doctor's office visit where you come in and you sit around, you know, for a while waiting, then you have an actual consult with your doctor. You know, you may have some blood drawn. So I would say our morning clinic patients probably spend about a half an hour coming in, getting their procedures taken care of, and then they're, you know, off to work. So most of the monitoring's done early in the morning.
Yeah, I was kind of wondering how a person that worked full time would be able to
the busy schedule
accommodate that.
Yes.
So you probably have to work all day long.
Well, I come in early in the morning, and actually most of our clinical work is done early in the morning. So the afternoons for me are paperwork.
Oh, okay. Now, I've heard that these treatments are expensive. What exactly is covered by insurance? Can you talk about that?
Well, you know, yeah, it depends on not only insurer but also on the employer. So there are, some of our larger insurers locally are things like Capital District Physicians Health Plan, Mohawk Valley Plan. There's all of the different blues that are out there. There is a state insurance, the Empire Plan for some of the state workers. And not only are, and then hosts of others, and I'm not trying to plug any particular insurance company, but it's very much employer dependent. So, that's one of the struggles. Patients who need to be very, very clear if they are having a fertility problem, they should investigate with their human resources people what is their coverage. If I had to say a general rule, virtually all insurance companies will pay for diagnosis. There are some that will only pay for diagnosis. So they'll do the testing and you'll find out that you don't have very good sperm, for example, but if you then want to have therapy, they're not going to pay for that. So it doesn't make a lot of sense. Many of the local plans do cover certainly the testing. We didn't talk about surgery at all. Surgery is a whole nother sort of parallel thing that runs. There's a whole host of reproductive surgeries. Those are typically covered. In particular, endometriosis is a disease that affects infertility, and the diagnosis of endometriosis and treatment for patients trying to get pregnant is a surgical one. So, and that is all typically covered for patients. Inseminations are typically covered to a limited degree. In other words, a certain number of cycles might be covered, but then beyond that number, there's no more coverage. Blood work and ultrasound monitoring, again, is covered for some, but not for others. The in vitro fertilization in New York State is not generally covered by most insurance companies. The plan for the New York State employees, there is a plan that does cover for New York State employees, and there are some private insurers that cover. I think another thing to keep in mind is where is the insurance derived from? So you may work for a large company where their home base is, in a state that, let's say Massachusetts, which has mandated coverage for in vitro, where you might actually be working in New York, but you have coverage out of Massachusetts. And so now you have coverage. And the converse may happen, where, I recently saw a patient who has a company that most other people with that insurance company would have coverage, but their plan is administered from California, and so California doesn't have coverage, and so, it gets very, very, very tricky. And the things that people need to be aware of is really that the insurance companies themselves don't really even know what they cover. And what they say to a patient may be, yes, we cover, for example, 6 IUI cycles. Well, okay, but an IUI cycle, intrauterine insemination cycle, may consist of numbers of things. It may consist of the actual IUI, the actual insemination. Okay, that part may be covered. But if we're doing it in combination with medications, well, what's your pharmacy plan? Are the medications also covered? And, and is the monitoring for that treatment covered, the blood work and ultrasound? So there are different aspects, the monitoring, drugs, and the procedures themselves. And so it does get pretty complicated, and certainly when patients come to specialty practices, like Albany IVF, we help them try to get through that morass of complicated, questions, and how do they ask, their human resources people, what is my coverage, and their insurance plan, what is my coverage, and also then potentially to advocate for coverage if some of what they're being told, may not actually be medically appropriate.
Right. They're never going to offer the coverage if nobody asks for it, right?
Correct.
Got it. Nobody pushes for it.
Correct.
Any final advice for couples trying to have a baby?
Don't wait.
Well, don't wait. Right. I think talk about it, is the main thing. I think, very often what happens is you know, at some level, the inner voice, more for the woman than the man. Women are about a decade ahead of men. So a 38-year-old woman is worrying about it much more than the average 38-year-old man. He'll catch up to her when he's 48. He'll be worrying about it, you know. It's about a decade difference. So one thing is if you think there's an issue, talk about it. You know, get that out in the open and understand that really what we help couples do technologically often is try to help them get pregnant. But getting pregnant is really only one facet of what is parenthood.
Right.
Okay? And so that's you know, golly, maybe we're having trouble. What would we do if? What if I have no sperm? How do we feel about adoption? How do we feel about donor sperm, donor egg? Some of the different things that as a fertility clinic we can offer patients, lots of different options, but not all of those options are the path to a genetic child of their own. You know, when we actually saw a couple this morning who's been a couple with us for a long time, and they have done every therapy you can think of. The woman's had multiple surgeries, multiple inseminations, multiple IVF attempts. They adopted a little girl and brought her home in December. And you know, they're still pursuing their treatment because they're hoping now for a SIB for their daughter. And their emotion, you know, they were smiling, they were you know, they were very hopeful of the cycle, but they were in a completely different place emotionally than when they started with us years ago.
Right.
Because they processed through, and you know, they have a daughter, they are parents now. And so their processing through the whole thing is much different, and I think getting to that point emotionally is probably the most difficult, but also the most critical thing that we help people do.
Well, thank you very much for coming. We are out of time for this show, but it's very good information. Thank you.
Thanks.
Thank you.
Thanks for watching. We hope to see you next time on Focus on Health.